Okay, this is the first lecture. I mean, this is the only lecture on the spinal cord. I'm sorry I missed the first couple of slides where we're going to go from here. So anyway, I think that's the story on those two enlargements. It's just because you have extremities that require a lot of extra nerve output to them. At the distal end of the spinal cord, it kind of comes to a point. That's called the conus medullaris, and then then coming off of the end of the spinal cord, there's a little thing called the filum terminale, which is a little thin thread of tissue that goes all the way down to the coccygeal ligament, and that basically holds the spinal cord there so it doesn't retract back up or anything like that. I'll show you a picture of that in a minute too. The last thing that you should be aware of is what's called the cauda equina. Even though there is no spinal cord down there in that lower part of the lower back below L1, there are a whole bunch of nerves that have come out up higher and then go down, and that's called the cauda equina. Equina means horse, cauda means tail, horse's tail. It's just a visual thing. It looks like a horse's tail because there's a whole bunch of nerves down there. So here's an example of the two enlargements. The one up in the cervical area where you see it gets a little bit wider up in here, not much, and the same thing down lower. It gets a little bit bigger down here too because it's sending off all the information to the lower leg. This one picture right here is probably basically what you need to know about the anatomy of the spinal cord at any level. One thing about the spinal cord is it's just the opposite of the brain. In other words, the gray matter is in the middle, is deep inside, and the white matter is on the outside. Now, I think I've made the point to you before that gray matter is gray because it has the nuclei and the cell bodies, the main part of the cells. White matter is nothing but a bunch of axons, myelinated axons generally, that are either running up or they're running down. In the center, there's a thing called the central canal. It's a little opening that actually is full of cerebrospinal fluid that connects all the way up to your brain. And then there's two sets of things coming out of it. The upper side, on the dorsal side, and this is the posterior side of the person, obviously, dorsal side, is the dorsal root. And the way you can tell the dorsal root from the ventral root is because the dorsal root has this big lump on it, and that's called the dorsal root ganglion. And indeed, that is where all the nerves, the sensory nerves, have their cell bodies are in that. And so from there on down, it's just a big axon going all the way down to your foot if necessary. And so those nerves come up, and that's where their cell body is. The lower side, so the upper end, the dorsal side, the dorsal root, is nothing but sensory fibers. Nothing but sensory fibers. It's just bringing information into the spinal cord and then sending it up to the brain. The lower side down here, the anterior surface, the ventral root, is nothing but motor. So all the motor information, when you want to tell your arm to bend, you make that decision somewhere, and the motor fibers are carried out through the ventral root here and then hook up into the spinal nerve. This is the spinal nerve here. And remember that spinal nerves are always mixed nerves. They have both motor and sensory, as you can see from those two contributions. If I could give you one other piece of advice that I think will help you a lot in answering questions about the spinal cord, if you just remember that if you could take the spinal cord and slice it right across the middle here, everything above that would pretty much be sensory, and everything below that would pretty much be motor. Okay? That's probably the most important concept. The way to remember it, once again, is that this is the dorsal root ganglion, which is where all the sensory nerves have their cell bodies. This is that this is the point that I was making about the spinal cord actually ends up here about L1. You can see the conus medullaris here, which is kind of the end of the spinal cord itself. And so from that point on down, it's nothing but just the nerves, the cauda equina. And so when we do spinal taps, the reason you do them down here, along in here, is because there is no spinal cord. If you put a needle into the spinal cord and happen to hit a little blood vessel, cause a little bleeding, but then cause a little pressure, you could actually cause the person to be paralyzed if you damage the spinal cord. So you don't ever want to put a needle into the spinal cord itself. But when you put a nerve in down here below the L1 level, it doesn't really matter because all that's down there is a bunch of nerves. And if you put your needle in and it tries to go into one of the nerves will just kind of bounce out of the way, and you'll be able to draw the spinal fluid out and so forth. Occasionally, if you watch a few spinal taps, a patient will suddenly get a terrible pain or a jerking motion when a needle does actually go into one of the nerves, but it doesn't really cause damage. You just pull it back out. Usually it passes right away anyway. But that's why we always do spinal taps down there. The spinal cord has 31 spinal cord segments. They're based on the vertebrae where the spinal cords originate, and they change a little bit with age as babies get bigger. Here's your lesson on naming the spinal nerves. This is the occiput, the skull bone, and then here's C1, C2, C3, C4, C5, C6, C7, and then what's the next one called? T1. That's right. Okay, so here's C1, also called the atlas. C2, also called the axis. C3, C4, C5. Okay, now there's a nerve that comes out between every vertebrae. Okay, that's why we got 31 of them. So the first one, which comes out right here between the skull and C1, is called C1. Got it? This one here is called C2. This is called C3. This is called C4. This is called C5. This is called C6. This is called C7. And this one here is the weirdo, because it's called C8. From that point forward, they're all named after the vertebrae above them. So this would be T1. Okay? T1, T2, all the way down to the coccygeals. Okay? So that's what I present it that way to help you understand what these last two lines here say. The cervical nerves are named for the inferior vertebrae, the vertebrae that's just below them. And that's why you have that extra C8 in there. And then all others are named for the one that's just above them. I already mentioned to you before, the ventral root contains nothing but the axons of motor nerves that are going out to the muscles. And the dorsal root contains nothing but sensory nerves coming in. A dorsal root ganglion is that lump that's on the dorsal root, and it contains the cell bodies of those sensory neurons. As I said already, the dorsal and ventral roots join up on each side, and when they do, they form the the spinal nerve. And remember that the spinal nerve is always a mixed nerve carrying both incoming afferent sensory and efferent motor going out. The other thing to remember is that the spinal nerves don't stay spinal nerves very long. They split up again pretty quickly. I think we've already talked about the meninges a little bit when we were up on the brain, but let's just review them here quickly. There's 3 layers around the spinal cord, just like there are around the brain. They are a continuation of the same thing. The outer layer is the really tough layer called the dura mater. The one in the middle is the kind of spider-like, flimsy coating called the arachnoid mater. I will give you all a piece of spinal cord in lab today so you can look at it. And I think the main thing you see on that is simply the 3 layers of meninges. You can also see the ventral rootlets and sensory and motor ventral and dorsal roots and so forth. But that's it's a very brief thing. There's not that much information you can glean from those little pieces of spinal cord that we'll give you. Okay, so dura, arachnoid, and pia. Pia mater is the most inner one. The pia pretty much clings right to the spinal cord. You can't really separate it off, just so you know. When we look at the spinal column in a cross section like this, once again you notice here here's the big dorsal root ganglion. So you know this is the dorsal side. Indeed, this is the posterior side. Then you have a couple of little ligaments here that you'll see nicely on the little spinal cords, the denticulate ligaments. They kind of keep the spinal cord from moving too far back and forth. Notice that there is the pia is right here, and just above the pia is the subarachnoid space. The subarachnoid space is the space that's full of cerebrospinal fluid. So when you're doing a spinal tap, or a subarachnoid tap, it's often called, you're putting a needle in through here, through the back, in between 2 vertebrae, going this way, and you're going to introduce it through the dura, through the arachnoid, which you will not feel. Sometimes you'll actually feel it go through the dura, and into this space here, which is just full of clear fluid. It should be full of clear fluid, the cerebrospinal fluid. Now, the other thing you guys have heard of, I know from your obstetrical experiences, which I think several of you have had in here, is epidurals, an epidural anesthetic. The way that works, you can get a spinal anesthetic, by the way, if you just, once you get the needle in here to the into this subarachnoid space, you put in a bunch of numbing medicine, and it numbs the spinal cord, for about that far, the nerves coming out of it, and gives you numbness. The problem with the subarachnoid block is you can only do it once, and that's it. You can't just go back and add a little dose here and a little dose there. Whereas with an epidural anesthetic, epidural is in this fat right here. It's not, you don't go in through the dura at all. It's on the outside of the dura, thus epidural. And you put a catheter, a little plastic catheter, into this space right here. You feed it in there a little bit, then you feed it in through the needle, which is a big needle. And then you take that out and leave the plastic catheter in there, run the catheter up the patient's back, usually tape it, and so the end of the catheter is sitting here on their shoulder where it's easy to get at. And the nurse can come along and give you a little more every half hour or hour. Sometimes they'll even hook it up to a pump and just let it dribble in. But they're putting anesthetic right here in the epidural space. It fills that epidural space and fills it north and south as well. And you can pretty much control the amount by how much you put in. The big advantage of that, of an epidural, is you can start off and put an epidural in for a lady who's in labor, for example. If you get it in early in labor and you just want her to kind of be numb from here to here maybe, and then she labors along and the baby's getting close, and if she needs more, you can give her more. But then if, for example, you came to the conclusion that she needed a C-section, she needed an operation, then you just give her a big dose through there, and that would then numb her up, say, from here to here, completely numb, usually, and then you can just wheel her into the delivery room, make an incision, take the baby out, sew her back up. She doesn't feel a thing. She's wide awake. She gets to see the baby born. She gets to do all those things that are so important, apparently, in the modern childbirth. And there's no question that epidural anesthesia is just state of the art for obstetrical anesthesia these days. The best thing about it is the baby gets none of the anesthesia. So the baby wakes up and is wide awake. Whereas back in the day, when you did a C-section, you had to put the mama to sleep. The problem with putting the mama to sleep was you also put the baby asleep. So now when you take the baby out, you've got a floppy, sleepy baby that can lead to serious problems, like cerebral palsy and real serious problems. So we hate to anesthetize the babies, because remember, once you deliver them, they got to breathe on their own, they've got to swallow on their own, they got to clear their own throat, they got to do all those things that are pretty darn important. The last couple things that are on this slide, I'm just going to mention them, although I think we'll come back to them. Notice that the dura here extends out and around the dorsal root ganglion, as you can see there. Note that the nerve is coming out between two vertebrae. We call that the intervertebral foramen, this hole on the side. I'll give you a better picture of it later. Also notice that there's these little nerves that come out here and go to this thing right here, which is called the autonomic chain ganglion, which is the sympathetic ganglion. I'll go into that a little bit later. And these are called the rami communicantes that send little fibers out there, and then some come back as well. So I think I've already mentioned this. The meninges are there to protect the spinal cord, carry the blood supply to the spinal cord, and they're continuous with the cranial meninges up at the top. Meningitis, you've heard that term, that is an infection of the meninges. Usually it's caused by bacteria or viruses, either one. I've mentioned these before, the dura, the arachnoid, and the pia, the three different layers. The tougher one is the outside one, the dura mater. It's the thing that tapers down at the bottom end in order to form the little phylum terminale that's going to go down all the way to the bottom of the spinal canal. And the epidural space is just on the outside of the dura mater. Mostly the epidural space is just full of fat and loose connective tissue. The arachnoid is the middle one. It's called arachnoid. You remember the movie Arachnophobia, which is a movie about people getting scared of spiders. Spiders, arachnoid, that's the same thing. It is the one in the middle. We call the epidural space on the outside of the dura, we call the subdural space between the arachnoid and the dura, just inside the dura, basically. The subarachnoid space is below the arachnoid, obviously, and it's the one that has all the cerebrospinal fluid in it that you're trying to get on a spinal tap, and so forth. A spinal tap is when you draw fluid out. I was a surgeon, and I didn't do that many spinal taps, but in my training, I probably did 50 of them, and we even did them on babies. It's amazing how they really are pretty easy. Just putting a needle in between two vertebrae, you kind of feel the vertebral spines and slip it in and slip it in until you can get fluid out. And clear fluid is you're in the right spot. We were usually doing it for diagnostic purposes. Why is the baby sick? Why is the baby got a fever? So forth. And when you draw that fluid out, then you look at it under the microscope. If it has a bunch of white cells in it, then you think, oh my gosh, there's an infection in here, and that's probably meningitis. The baby's going to go on antibiotics. There's a lot of other tests that you can do on the spinal tap that will tell you a lot about the baby's condition and so forth. Pia mater is the innermost one. Like I said, it's totally bound to the underlying neural tissue, so you won't be able to peel it off of your spinal cords that we get in lab today. On either side, there's those denticulate ligaments that I mentioned. They stabilize the side-to-side movements. There's also a bunch of blood vessels along the surface of the pia, and they supply blood to everything in there. Here's a nice close-up. You can see the blood vessels here that supply the spinal cord. You also see that those denticulate ligaments right here that keep the thing from moving side to side. You see the little rootlets. There's actually a bunch of rootlets, but they come together to form a single root. This looks like this is the dorsal root here, and then from the back side, back in behind there is where the ventral root comes out. I've already told you this too, the white matter and the gray matter. White matter is more superficial. When you get to the brain now, though, the gray matter will be on the outside. The gray horns, I'll just say that I'll point it in on a picture here in a minute. But once again, this goes back to that comment that I made that the stuff above is all sensory and the stuff below is all motor. There are these gray commissures and whenever you hear the word commissure, here's a hint for you. Whenever you hear the word commissure, think messages traveling from one side to the other, okay? So, you know, when we step on that pin, for example, and we lifted that foot up, in order to lift our left foot up, we had to push our right foot away from it, right? So both sides need to communicate. And so whenever you hear that word commissure, and this will hold true in the brain as well, that whenever you hear the word commissure, that means stuff that's crossing over from side to side, from the right side to the left side. I'd just as soon you go and advance the slide there instead of making a noise. Come on. Another word you ought to know is nuclei. Nuclei in the nervous system means that that's a collection of cell bodies. We have sensory nuclei that are on the dorsal side that connect all the way out to those peripheral receptors. We have motor nuclei that are on the ventral side of the spinal cord, and they connect out to the peripheral effectors, basically the muscles and the glands, things like that. The other thing about the spinal cord, and you're going to learn this about the brain as well, everything is very perfectly organized. The body from top to bottom is organized by spinal level, different levels. The nerves coming out tend to innervate a single layer here. We'll talk about that. So just know that they're very organized. Posterior white columns are if they're posterior, what are they going to be? Sensory or motor? They're going to be sensory, right? So these posterior white columns are going to be carrying messages up to the brain because they're sensory. And if we go down here, along the lateral side, they're kind of mixed. And the ones on the anterior side are going to be carrying things down in order to supply muscles. I'll just leave it at that. The white matter, which is nothing but axons, remember, of nerves that are going up and down the spinal cord, either carrying information up to the brain or sending messages down from the brain to tell us to move something, for example. They're in the white columns, and they're kind of in bundles, but not really. You can't see them even under a microscope that they're in bundles, but just know that they are organized in these manners. I'll show you pictures to say, but just know that we call some of them ascending tracts because they're carrying messages up to the brain, and some of them we call descending tracts because they're carrying motor commands down to the spinal cord. So here's kind of a diagram that illustrates that. And I think this is certainly the most you need to know, probably more than you need to know about the spinal cord. I think the most important thing you know is that if you slice the thing across the middle here, that the things on the top, on the dorsal side, are going to be sensory. Both the gray matter is sensory and the white matter is sensory. And in the lower half down here, the gray matter is motor and the white matter is motor. Because remember, it's going to be coming out here, out the ventral roots for motor, and out the dorsal root is where it's coming in for sensory. You see that they call this the anterior gray horn, the lateral gray horn, and the posterior gray horn. Okay, that's fine. Then these white areas out here are called lateral white columns. These would be called the posterior white columns up in here, and these would be called the anterior white columns down here. Notice that there are two areas of gray commissures. The anterior gray commissures, see this is gray matter, and this is the part that's carrying messages back and forth from side to side. So this is the anterior gray commissure, and just on behind the central canal here is the posterior gray commissure, also carrying messages from side to side. I don't think you need to be concerned about these visceral and somatic areas. Here's what the thing really looks like. We have nice slides of the spinal cord over in the lab. I think it's very hard because you can't really get this whole thing in one view. It's really hard to test off of the slides. So I think I've already told you you'll be tested off of pictures like this. And once again, this is the same as the previous picture. Once again, here's this anterior gray commissure, posterior gray commissure, lateral horn, anterior gray horn, anterior and posterior gray horn. Here's the sensory root, or the dorsal root. Notice it goes to this big ganglion here. And if you're looking around in the ganglion, you'll see a lot of the neurons, the nerve cells, that are in there. There's also a bunch of satellite cells in there that sort of take care of those nerve cells as well. And then here's the ventral root coming in here. This is pretty typical. It's all cut up here, sort of. But this is the dura that you're looking at right out here. And it's going to be on the outside of everything. This is going to be the arachnoid. And it says this is the dura. Okay, dura. Arachnoid is all broken up along in here, and pia then is really firmly attached to the neural structures there. The central canal is surrounded by what kind of cells? What are the cells that manufacture CSF and maintain CSF? And they're not called, I don't remember. They're called ependymal cells. Remember, ependymal cells. I'd probably want to know that if I was you. That's so cute. It's an old one, isn't it? Okay. I just reinforce this point here that the spinal cord is very highly organized, and you can predict exactly what a certain injury would make, what it would cause. In other words, you can take at any level of the spinal cord, and if you froze or cut, somehow this got cut in an injury, that area right there, you could figure out exactly where it was because it's a very exact, it's very exactly organized. Okay. Let's talk about the spinal nerves for just a minute. Each of the spinal nerves is a mixed nerve, as I've already said. Every spinal segment, every cord segment, it's not really divided into segments, but you just got to think of it like that, because each one of these nerves that's coming out over there has an area of the spinal cord that it's coming from. Okay. Each spinal nerve is surrounded by 3 connective tissue layers. You remember those? Endoneurium, perineurium, and exoneurium, epineurium, outside is epineuriums. Okay, good. Oh, there they are. Wow. Okay, enough said. Here's what they look like. Here's what a nerve looks like. Epineurium covering the entire thing. Epineurium, remember, is oftentimes will be then coated with myelin, put on by what kind of cells make myelin in the peripheral nervous system? Schwann cells. Very good. So epineurium's on the outside. Perineurium is around each one of these little fascicles. And then endoneurium surrounds each one of the little tiny ones, as you see right here. Nice picture. Well, let's talk about the peripheral nerves, because just because these nerves all come out in a nice orderly fashion like this, they don't stay that way. So I'm just going to take and kind of give you an example of what I mean. I mean, some of these nerves are going to come out here, and they're going to hook up with each other, and then they're going to go on out here, and then they're going to hook up with each other again, and then to make different nerves. You don't have to memorize all that stuff, but just know that the nerves don't stay as single spinal nerves all the way out in the periphery. And we're going to also talk about the plexuses that where they really get scrambled. So these spinal nerves form just lateral to the intervertebral foramen, which are the holes out the sides, basically. And they begin where the dorsal and the ventral roots unite. And then they branch and form a bunch of different pathways to spread all out. This is the little white rami and gray ramus, the communicantes. The white ramus carries muscle fibers, or visceral muscle fibers, to the sympathetic ganglion. Sympathetic ganglion, sympathetic means sympathetic nervous system, fight or flight. Gray ramus is the ones that come back from it. They're unmyelinated. They return from the sympathetic ganglion and then rejoin the spinal nerves. So basically what this is working out a way to get the messages from the fight or flight centers up here, send those messages out through these ganglions and then jump onto other nerves to carry the signals out that make your blood vessels open up or close down, make your arteries open up, close down, and so forth. Okay, when these nerves come out, they split into a dorsal and ventral ramus. Now what that means is the dorsal ramus of the nerves, of each of these nerves, goes to supply the middle of your back. Okay? So if I was a skunk and had a white stripe down my back, that's about the whole area that is served by the dorsal ramus. It just innervates the back. The ventral ramus is the one that comes on around from each level and serves the whole body. So the ventral ramus is much larger. Just think of the dorsal ramus as the skunk stripe. It goes to the muscles that are right there in the middle, and it goes to sensation. It supplies sensation to the skunk stripe back there. This is just a schematic illustrating what I just told you about the sympathetic chain ganglions here and the two little tiny nerves, the white rami and the gray rami, that connect to the sympathetic chain. This just has to do with the autonomic nervous system with the fight or flight nerves. This is the main parts of the nerve right here. This is the dorsal ramus, which goes to the skunk stripe. This is the ventral ramus that goes to the rest of the body. So the ventral ramus goes all the way around to serve you in front. Let's talk about dermatomes for just a minute. Dermatomes look like this. This is the front of the body, and this is the back of the body. But basically, what this is saying is that, you know, the C1, that's not C1. Yeah, it is. I can hardly read it from up here, I'm so close. These are the different layers that are served by these cranial nerves. Now, let me just tell you that I think there's about 3 of them that you ought to know. I think you ought to know that the top of the shoulder is C2, C1, right in there. Is it C4?
Yes.
Thank you. You're right, C4. I knew that. C4. The little finger, you think about it in an anatomic position, the little finger is C8 or T1. C8, T1 is the little finger. You ought to know that the nipple line is T10, right along in here. I can't read the numbers.
It's T3.
Okay.
Well, if you want to go like.
And the belly button is T10, right?
Yeah.
Okay. Yeah. Now, the reason those actually are something you use a lot in this hospital, especially if somebody's getting the spinal spinal anesthetic put in. Then you're taking a needle and testing where do you get numb. You know, you kind of mark it up, and mark it down, and say, oh, the patient is numb from T10 down, or whatever. And that becomes really important in those epidurals, those pregnant ladies, is figuring out where they're really numb. And so you're testing it, and you're thinking about these dermatomes right here as to what nerve has been numbed. And you can monitor it. So it may start off up here, but it comes down to here, and you better be thinking about giving them more medicine to get it back up there, or suddenly the patient's going to be in terrible pain. So you're kind of thinking about this. This also is important in the disease called shingles. You guys have seen ads on TV about shingles, and shingles are caused by the chickenpox virus, and most everybody had the chickenpox. When I was a kid, and somebody in the neighborhood got chickenpox, you had a chickenpox party, and everybody would come over and try to get all the kids to catch chickenpox, and usually they did. Then, you know, when you got chickenpox, you were sick for 3 or 4 days, but you had it. You didn't ever have to worry about getting it again. The problem with those viruses don't ever really go out of your body. Some of them live on in the dorsal root ganglions, in those sensory fibers, in the sensory ganglions just outside the spinal cord. And then later in life, they can become reactivated. And when they do, they're very painful. They're called the shingles because it leads to a layer of like shingles, you know, layer after layer after layer of shingles, of not only rash, but also very severe pain. My story on shingles came from my Uncle Bill, who died a few years ago. And about 10 years before that, maybe 5 years before he died, he got the shingles, and it never went away. Usually it just hangs around for a month or two, but some patients get it, and it lasts forever. We now have a shot you can take, and Uncle Bill had his involved the upper part of his face back into his scalp here, and a little breath of air would blow over his skin and just send him into incredible pain. You could just see the guy he lived for 5 years in constant pain. He'd been to pain clinics, he got all these different drugs and tried to make it better, but really nothing helped. He died in agony from the shingles. And one time when I went to visit him, he pulls me down. He says, "Hal, have you had a shingles shot yet?" And I said, "No." He said, "Whatever you do, get a shingles shot as soon as you can." Well, back then I wasn't 55, and you couldn't get them until you were 55 years old back then. Now I think you can get them a good bit younger. And I went in, I have Kaiser health insurance. I went into the Kaiser clinic one time. They had a big thing that said, there's a little booth set up out in the hall that said shingles shots. And you just walked in and said, "Yeah, I'd like to have a shingles shot." And I think at that time you had to be 40. And I got mine. It's a once a lifetime for a lifetime protection. But man, I don't ever want to get that. It's awful. I only had one patient in my life ask me to kill them. As a physician, you would think you'd hear that once in a while, people that are in terrible agony, and it was a guy with shingles. I went in to make rounds on him one day. I was seeing him for another problem completely, but he said, "Doc, can you give me something that just let me go to sleep for good? Tired of this." It's an awful disease. I didn't give it to him, by the way. Usually it's a drop in your immunity. So patients who develop cancer, that'll often do it. A lot of times it's just people getting older and their immune system isn't as strong as it was to keep it in check. Peripheral neuropathy is a problem with the peripheral nerves. It can lead you to have a loss of sensation or motor function in that particular area. Usually it's caused by an injury to the nerve way upstream, which then makes the nerve unresponsive the rest of the way down. Here's an example of the shingles down in the thoracic. I think the belly button is T10, right? Yeah, so this would be about T12.
So it follows the nerve?
Yeah, it follows the nerve. Because the virus is living in that dorsal root ganglion of that one nerve. And virus travels out through the nerve and gives you that rash and that pain in that distribution. Let's talk about the nerve plexuses for just a minute. Please know that you do not have to memorize these. They're very complicated. Sometime in the winter term, towards the end of winter term, I usually take a group of students out to the chiropractic college to look at their cadavers. They dissect cadavers out there. They have a wonderful lab, and they show us all around. They completely dissect out these nerve plexi, and they're just so beautiful the way they clean them out. So pay attention to signs around the department here, maybe towards the end of next term, and then I usually do it again in June or May, towards the end of the term, towards the end of the academic year. We have 4 major plexuses, and remember that these plexuses only involve the ventral rami. They do not involve the skunk stripe branch. They only involve the ventral rami that come around in front. There's the cervical plexus up here in the neck. There's the brachial plexus, which really serves the arm. There's a lumbar plexus that kind of serves the lumbar and pelvic area. And then there's a sacral plexus that involves even lower yet. So here's an example of the cervical and brachial plexuses. And you notice that the reason they're called plexuses is because these nerves, they come out at the different levels from C1 all the way down here to, say, T3 or so. And then they come together, they join up, and then they hook up, and they rejoin up again, and so forth. in order to account for these different nerves that actually are the nerves that go down the arm. There's only one nerve on this whole slide here that I think you should know something about, and that is the phrenic nerve. The phrenic nerve is important. The phrenic nerve, anybody know why the phrenic nerve is important? It's the one that goes to your diaphragm. It makes you breathe. And if you notice, the phrenic nerve is innervated up here by C3, C4, and C5. Okay? Now, why is that important? Well, here's why it's important. You guys remember Superman, Christopher Reeve? He was riding a horse one day at a horse show, and the horse jumped over this thing, only it didn't jump just right. He goes flipping over, lands straight on his head, and he is immediately in deep trouble. He breaks his neck, and he broke his neck at the C1 level. Now, when you break your neck at the C1 level, that's a bad deal because you've broken your neck and you cut his spinal cord higher than C3, 4, and 5, which is the phrenic nerve, which would have made him breathe. So he could not breathe a breath, and he never breathed a breath the rest of his life. Luckily, there was a doctor sitting right there at this horse show, and he had a laryngoscope and he had an endotracheal tube, and he ran over to him, saw what was going on, saw that he couldn't breathe, looked in his throat, intubated him, and started breathing for him, and saved his life. Christopher lived about another 8 years, I think. He was in a wheelchair. He was a quadriplegic. He couldn't move anything below about here. Couldn't move his arms at all. He ran his cart with a mouthpiece to, he could move around a little bit. And he had a ventilator breathing for him all the time. He died of a blood clot, which is what most of them die of. Because since their muscles in their legs never move, they never get to use their muscular pump. Remember? I guess y'all haven't had that yet. I'm sorry. That's 232. But anyway, the blood just kind of pools there and it clots and breaks off and goes to the heart and kills them. Okay, so that's the phrenic nerve. That's the one that makes you breathe. Farther on down, here's the lumbar plexus and the sacral plexus. I think it's important that you know something about this one here, this really big nerve right here, which is basically the nerve that's going to go to your foot and your lower leg. It makes all the muscles in your leg work, and it's called the sciatic nerve. And you've probably heard of that one before too. So I think I'll just kind of slide through that. Here's a close-up of the phrenic and how this whole thing is formed. But I think it's always amazing when you think about the fact that we breathe. The thing that innervates our diaphragm way down here comes from way up here. And the phrenic nerve carries that information down there. Here's the phrenic nerve right here. Okay. The brachial plexus is really interesting. It's of the arm. We have, here it is. You see they come off from between C4 and T1. They group up, then they regroup up, and then they regroup up, basically. And they end up, by the time they get down to their hand, you have 3 nerves. And I'm going to teach you these because I think you ought to know this. The 3 nerves that innervate your hand are called the median nerve, the ulnar nerve, and the radial nerve. Okay? And the median nerve is significant. It's the one that runs right through here underneath that flexor retinaculum, which is the one that gives you carpal tunnel syndrome. So if you have carpal tunnel syndrome, you're going to have numbness and pain in your thumb, these 2 fingers, and half of this finger. You will never have pain in your little finger. See that? Because the little finger is completely served by the ulnar nerve. And the median nerve, so that's the median nerve, and then the radial nerve basically just innervates the back of your hand back here. So, if you wanted to test somebody to make sure that all three of their nerves are intact, it's a really simple thing to do. What you do for the ulnar nerve is you touch them out here on the lateral side of their hand, and if they can feel that, their ulnar nerve is intact. If you have them test them and see if they can feel you when you touch the tip of their finger, and they can, that tells you that their median nerve is intact. And in order to test for the radial nerve, you go right over here and you grab them right here in the web of their thumb, and you feel that. And for people that have had injuries of their arm, that's something you kind of always need to do to make sure that none of the nerves got damaged. But that's the distribution. Once again, this is just way over your heads. You don't need to know that. Lumbar plexus, pretty much the same thing. I'll leave it at that. Here's the sciatic nerve, the other one that I said you ought to know, ought to at least know the name of. The foot has 4 nerves that serve it, but I'm not going to ask you to learn those. It seems like we never ended up having to test that. I guess it's people don't get as many injuries of their legs as they do of their arms, but the knife and gun club seems to work quite well on the upper extremity. Okay, a couple of comments about nerves in general. We have about 10 million sensory neurons. I'm not asking you to know the number, but just think of, but you do need to think about them relative numbers. So we have about 10 million sensory neurons that are bringing information up to our brain, and then we only have about 500,000, 1/20th as many nerves carrying signals out to our muscles to make our muscles work. So we have about 500,000 motor neurons. But where we really have the neurons is what's called interneurons. Interneurons are neurons, nerve cells that connect one nerve cell to another nerve cell, which is basically all your brain, and lots of connections in your spinal cord and so forth are interneurons. So the 20 billion, what is that? 200,000 times more? I don't know. A lot of zeros, because a billion has 9 zeros and a million has 6 zeros, so it's a lot more. How do these things work, and how do some of these reflexes work? Well, let me just say that for a neural reflex to work, you have to have a stimulus that stimulates something. The stimulus arrives, like the pin I stepped on, and then that activates a sensory neuron, and that sensory neuron then carries the signal up to your spinal cord, where it processes on a postsynaptic cell. So in other words, the sensory nerve carries the information up here. It hooks onto another cell by using neurotransmitters. It activates a motor neuron, and then the motor neuron carries the information back in order to make you lift your leg up off the pin. Okay? Now that's the simplest of reflexes. That is a single synapse, a monosynaptic reflex. Monosynaptic, one synapse, which is also the quickest kind of reflex, because every time you go through a synapse, remember, there's a little delay that takes place. So this would be a reflex arc right here. This is actually has 2. Here's the pin. The receptor picks it up, carries the message up here through the dorsal root. There's the cell body right there, and then it carries it on into the spinal cord here. This one is not a single one; it's a double. So it synapses on this neuron here, and then this neuron it's an interneuron, and it synapses on this motor neuron. Here's the motor neuron that then goes out through the ventral root, back down to the muscle, and it makes you pull your hand back from it. Okay. So, also you notice that this interneuron has another branch that then takes it on up to the brain. But you've already lifted your foot off, or your fingers here off of the pin before it even gets up to the brain. We have a bunch of different kinds of reflexes, and please don't try to memorize every one of these, but I'd just like to talk to you about a few of them because I think they're so cool. We have certain ones that are called innate reflexes. In other words, we're born with them. Okay? Now, how many of you have had a baby around the house? And if so, have you ever taken the baby and held him out on the bed and dropped him? Maybe 4 inches. Not going to hurt the baby. Or seen a baby fall. What do? That's right. That's called the Moro, M-O-R-O reflex. And all babies will do that until about 6 months of age. Every time they get dropped or they lose their balance or something, they'll go like that. Arms and legs both will go out. Why is that? Well, take it back in evolution a little bit. Take it back to when we used to live in trees.
To look bigger.
Huh?
To look bigger. To look bigger. In ecology,
No.
it's supposed to look bigger.
No, it's so that if the mama drops the baby, she's got a chance to swoop down and grab him. There's 4 arms, there's 2 arms and 2 legs that are sticking out there that she can grab. Because obviously, if she don't grab it, that baby's probably gonzo. So that's a Moro reflex. There's several other reflexes that occur in a baby. If you take, if they're really young and you touch them on the side of their mouth, what do? You know, they're figuring that must be a nipple, and they got to turn their head a little bit, and they got to start sucking. That's an innate reflex. We don't make that one. They get born with that one. In fact, you know, within 2 minutes of being born, you can put the baby up on the breast, and he'll go to town on it, usually. A lot of our reflexes are more learned, and I just leave it at that. We have a bunch of visceral. Well, let's talk about somatic reflexes. That's like the one examples I've given you of pulling back from something sharp or something hot. There's visceral reflexes, which are autonomic. That's things that you might see that look really gross and you vomit or feel really bad. Those are, that's due to control of the smooth muscles and the cardiac muscles and glands. You might faint, would be another example. Your heart goes slow. Monosynaptics are just one synapse. Polysynaptics are between 2 and several hundred synapses to make happen. Most of the reflexes that we've been talking about here are spinal reflexes, but then a lot of the reflexes actually occur in the brain. Obviously, the Moro reflex, the suckling reflex, those are reflexes that occur in the brain. And just remember, if it takes you thinking about it, that means it had to go all the way up to your brain, so it can't be a spinal cord reflex. So if the tiger walks in the room and suddenly you're really scared, that's not a spinal reflex. That happened in your brain because your spinal cord doesn't know what a tiger looks like, right? I think I'm just going to kind of slide through these. These are really quickie ones. This one's kind of nice. You should practice this over in the lab. I'll help you a little bit with it. Thumping on the knee. What you're doing is you're stretching the tendon of your knee, of your quad. It's called your patellar tendon, right? Just below the patella there. And when you hit it with a little reflex hammer and you stretch it, then it tries to fight that, and you kick out. You guys have all seen that one. I'm going to slide through these guys here. This is what a muscle spindle looks like. I'll see if I can't get Melissa to find that. We have some slides of these that are just gorgeous. A muscle spindle is a sensory receptor that lives in muscle, within the muscle itself, in order to control the tension of the muscle. So, based on how much it stretches, it sends fibers both back to the CNS, and also we get signals sent down from the CNS to tell us to keep our muscles at a certain tension level. I think you should know about these guys. Read about that in the book. Tendon reflexes I just mentioned. Let's talk about withdrawal reflexes for just a second. Most reflexes are flexor reflexes. For example, if I put my finger down on a hot stove, I flex my elbow, I flex my shoulder, flex everything in order to get my hand off of it. So that would be an example of a flexor reflex that is a withdrawal reflex. Here it is right here, illustrated: pain, hot, sends a message up through the dorsal root into the spinal cord, one inner neuron here, and then it sends messages down here to the biceps to flex, to pull it off, right? Now the thing about it is, you got to realize is that when you go to pull your finger up off that painful thing, you not only have to flex your flexors, but you want to relax your extensors, okay? So that's why you see this here. You see the flexors are stimulated, but the extensors are inhibited, because you can't, if you're still tight, holding your triceps tight, you can't do it. So you have to stimulate one and inhibit the other. That's what the reciprocal inhibition is about. The last one I want to mention to you that you should, I think, know about is this one called the cross extensor reflex. And that is what I actually mentioned to you earlier. But basically, if you step on a nail with this foot, you want to pull your foot back up. But it's really more complex than that, because not only do you want to pull your foot back up, but you want to push down on this one. Okay, so that's the crossed extensor. It's going to the other side. So this leg extends while this one flexes in order to get your foot up off of that painful thing. That make sense? It's called a contralateral reflex arc. What does contralateral mean? The opposite side. What's the same side? Ipsilateral, right? And it's just restating the same thing. So here we are. We're pushing down with one foot while we're pulling up on the other. I'm going to slide through these pretty quickly because I think they're just a little too in-depth. Let's talk about the Babinski reflex for just a minute. This is something that you ought to know about. We use this all the time in evaluating patients that have had head injuries or any kind of injury, really. This is normal. This is the normal reflex. When you scrape the bottom of someone's foot, they should curl their toes and withdraw their foot. However, if they've had a spinal cord injury or a nerve injury above that level, they won't do this. They'll do this. Their toe will go out. That's a bad sign in general. Babinski's are bad. The only exception is in babies. For about the first 3 to 6 months of life, Babinski sign is normal in kiddos. But later in life, when you want this plantar reflex, this is the one that's normal. This is the one that's abnormal. And this one generally means there's been nerve damage between the brain and the leg, and that's why it says here the brain can alter some of these reflexes. That's what it's doing in Babinski's sign. Wow, I'm done. I have a couple of videos that run a minute and a half or so. I'll show them to you over in lab. I have your quizzes back after all of the hubbub with the quizzes yesterday. I decided, what the heck, I'll just throw all those questions out. That's what I did. And so it was a 14-point quiz, which then I had to factor up to 20 with a calculator. There wasn't much extra credit earned, but there was a few. And I would say that several of you made more than perfect, which is always kind of nice. Anita, Sorky, Heidi, she's not here. Tamara. Good job. Good job. Kyle Witter. Arielle. Alex. Alexis Anderson. And Sherry. This would have been a good bit better.
Showed up.
I didn't get your note, by the way, until after class.
Oh, that's
Ellie. Bethany Blackman. Elatania. Rachel. Jen. Dana. Thyra. Tira. Oh, she is here. That's right. Karen Anderson. She's here. Lindsay Pickett. Yes, watch your step there. Jennifer Macias. And Jacqueline Corus. Why don't you take this to her? Carissa Manel. Kevin Jones. Kevin Jones. Stephanie Lay. I'd say this Stephanie Lake is something else. 15 out of 14. Okay, good job, Stephanie. Okay.
I feel better about all those questions being thrown out.
It's fine. Good. I went through the exam, by the way. I looked over every question. And the only thing I would tell you about origins and insertions is you might want to know what inserts into the olecranon.
Yeah.
I don't know. I mean, you know, part of the issue there with me is that that's something we actually discussed back in bones. When we were discussing the bones and the olecranon.
You want to give us a couple more?
No. No, that's the only one that doesn't come off the list of bones, or is an origin and insertion question. It's not really even an origin and insertion question. It's